Hello and welcome to our series of lectures on endocrine pathology. This is lecture 1. In this particular lecture, we are going to discuss about thyroid neoplasia. Thyroid neoplasia simply refers to the tumor formation within the thyroid gland. So these nodules typically present as a distinct, solitary and painless nodule. Thyroid nodules are more commonly benign than malignant. Only about 8 to 10% of the palpable nodules are malignant in nature. So when a person has a thyroid nodule and you are really worried about, you can do iodine optic studies. So the radioactive iodine optic study is usually done to distinguish between a hot nodule and a cold nodule. So when there is increased uptake, then the nodule is said to be a hot nodule. Here in the picture we can see a hot nodule, and in case of adenoma and carcinoma there is decreased uptake and we call that nodule is a cold nodule. Therefore, decreased radioactive uptake warrants FNA biopsy. FNA biopsy is actually done to distinguish or differentiate the carcinoma histopathologically. Talking about thyroid adenoma, this is one of the most common variant of the thyroid adenoma in the benign condition. So this is the benign and solitary growth of the thyroid follicles. Here we can see the benign and solitary growth of these thyroid follicles, and most cases of thyroid adenoma are non-functional. It means they are cold nodule, but in a rare condition they can cause hyperthyroidism because of autonomous thyroid hormone production. So if these thyroid adenoma are producing thyroid hormone in an autonomous manner, then we call that nodule is a hot nodule or a toxic adenoma. So we can see here most common histopathology of the thyroid adenoma. So the follicular pattern of histopathology is seen, and here we can see the follicular cells which are well capsulated, and these follicular cells are proliferating in a benign manner, and all these follicular cells are contained within this capsule. So this is the case of thyroid adenoma. Regarding about thyroid carcinoma, so thyroid carcinoma is usually distinguished by fine needle aspiration. So fine needle aspiration provides cytopathological diagnosis of the four varieties of thyroid carcinoma. Under ultrasound, there will be the areas of hypoechogenicity and increased vascularity within the nodules, that is intranodular hypervascularity, along with intranodular microcalcifications, and all these indicates increased risk for malignancy. We need not do radioactive iodine thyroid SNT scanning when there is normal level of TSS and toxic nodule, because that well establishes that our nodule is carcinoma in nature. But if there is low TSS and toxic nodule, then only we have to proceed through iodine 131 studies. And the most common treatment for the thyroid carcinoma is radioactive ablation of the thyroid gland as well as thyroidectomy. So there are certain complications which are arising with the thyroidectomy, and most common complication is one of the obvious complication, that is deficiency of thyroid hormone, because we are ablating thyroid gland. We are cutting down thyroid gland from the body. That's why the person will be deficient on the thyroid hormone. That's why thyroid supplement must be given throughout their life. And other complications include hypocalcemia because of removal of parathyroid gland, and because of transection of recurrent laryngeal nerve, there can be during the ligation of this inferior thyroid artery, there can be dysphagia and dysphonia, that is hoarseness of voice. And if we transect this external laryngeal nerve, then there can be the conditions like loss of tenor of voice, but it is usually noticeable only in case of professional voice users. That's why during the ligation of the superior thyroid artery, it must be ligated towards the apex of the gland, so that this extralaryngeal nerve can be prevented from being transected. And during the ligation of this inferior thyroid artery, it must be ligated away from the nerve that towards the base, so that this inferior thyroid artery can be spared from being transected. So this is about the transection of about the diagnosis and treatment of the thyroid nodules. And talking about the four variant of the thyroid carcinoma, so we go like papillary, follicular, medullary, and anaplastic. And papillary carcinoma is the most common most common variant of this thyroid carcinoma. And although this carcinoma spreads via lymphatics into the cervical lymph nodes, this carcinoma has an excellent prognosis. So they are usually seen in 80 to 85% of the patient, of 80 to 85% of the variant are papillary in nature. So though being the most common and metastasizing through the lymphatics, they carry the excellent prognosis. So this can be our plus point. And regarding the risk factor for papillary carcinoma, one of the major risk factor is that when a patient is irradiated during his childhood for the severe acne around his face, so that the thyroid gland is irradiated without any intention of being irradiated. And when first condition is that, and second condition is that in case of survivors of the major nuclear disaster, where they get the all over irradiation of the whole body from the nuclear disasters, they also have increased risks of developing papillary carcinoma later in their life. Regarding about the microscopy of the papillary carcinoma, we can see here papillary front like structure. So here we can see finger like projection with the, and this papillary front they poses neurovascular stalk, and these cells have dispersed chromatin. So one individual cell. So if we start seeing one individual cell, we can see it like this. So here in the picture we can see one individual cells with their chromatin being dispersed outside, but nucleus of them is prominent in the center. That's why the condition is like this. Here in the white section I can draw like this. So if this is the nucleus, the chromatin gets dispersed outside. This is the dispersed chromatin, and the nuclei of these cells are prominent. That's why this structure is like the eye, orphan any eye, which is one of the cartoon characters. So this is like the eye of this orphan any, so we call it orphan any eye appearances. And also there are presence of the nuclear groove. So here in the picture we can see grooving of the nucleus. So this dark line at the center of this cell, so at the cells, and at the center of these cells, this dark grooving like structure, these are the nuclear grooving. So papillary carcinoma must be distinguished on its nuclear structure. So the presence of the finger like projection indicates that this might be the papillary variant, but the nuclear character, nuclear details is what helps us to establish the diagnosis. So we can see the orphan any appearance, which is the clearing of the nuclei and the presence of nuclear groups. They indicate that these lesions are papillary carcinoma in nature. So other structure, other details like the presence of samoma bodies. So samoma bodies are actually, these are the laminated and concentric. So these are the laminated and concentric rolls with the dystrophic calcifications. These are called as the samoma bodies, and these are the concentric calcifications of individual necrotic tumor cells. But this samoma body, presence of samoma body is not actually pathognomic to the papillary carcinoma of the thyroid, because there are other conditions as well where we can say samoma body. So other conditions include of course the first condition is papillary carcinoma of the thyroid. There can be somatostatinoma, there can be meningioma, there can be malignant mesothelioma, there can be ovarian serous papillary cyst adenocarcinoma, and there can be prolactinoma. So these are other conditions in which psammoma bodies can be seen. So psammoma bodies, presence of psammoma body is not pathognomic to the papillary carcinoma of the thyroid. So most pathognomic is the orphaninae appearance with the nuclear grooving, and in addition to the presence of psammoma body. So genetics, one of the genetic pathogenetic pathway is that the mutation of BRAF and the translocation, that is the rate and receptor tyrosine kinase activating mutations. Rate PTC translocation, we call it a rate PTC translocation, and this is the genetic mechanism of the development of papillary carcinoma. So here we deal about the papillary carcinoma, but whatever among all of these, what we have to remember is that the papillary carcinoma are most common, about 80 to 85% of the variant of thyroid carcinoma are papillary carcinoma, and these are more prevalent and presence of palpable lymph nodes, and they have good prognosis. Regarding follicular carcinoma, we need to distinguish follicular carcinoma from the follicular adenoma. So follicular carcinoma is that these tumor cells, okay, here the tumor cells, they are invading through this capsule. So in a normal sense, this capsule must have to be intact, but these tumor cells, they are invading through the capsule. So these are the follicular carcinomas. And one point we have to establish here is that if we are taking FNAC biopsy from this point, then we cannot see the proper integrity of the capsule. That's why FNA cannot actually distinguish between follicular adenoma and follicular carcinoma. That's why FNA is not that much appropriate to distinguish in between the follicular adenoma and the carcinoma. And one of the other high yield point on follicular carcinoma is that follicular carcinoma, so being a carcinoma, it must be metastasizing through the lymphatics, because carcinoma generally metastasize through the lymphatic route, but the follicular carcinoma is one of such carcinomas which metastasize through the blood vessels. So we also need to keep in mind about this point, and they actually invade to the blood vessels and they spread to bones, lungs and liver, and lymph node involvement are rare in this condition. So they are actually distinguished from the from adenoma variant by the presence of uniform follicles and with capsular and vascular invasion, and the genetic factor is there is RAS oncogene mutation and PAX8 and PPR gamma translocation. Here in the figure we can see the metastasizing route of the follicular carcinoma. So here we can see, we can have a clear concept that these are the malignant cells and they are invading through the capsule. That's why these are the follicular cells invading through the capsule. So this must be the follicular carcinoma. And here in the picture we can see this is the blood vessel. So this is the this indicates the wall of the blood vessels, and these follicular cells are growing through the walls of the blood vessels, and hence we can be clear that the follicular carcinoma, they are usually metastasizing through the hematogenous route. So other carcinoma which actually metastasize through the hematogenous route include renal cell carcinoma through the renal veins, hepatocellular carcinoma through the hepatic veins, follicular carcinoma of the thyroid that we just talked about, and choriocarcinoma. So we have to remember these four carcinoma which metastasize through the hematogenous route. Regarding other point, we can go about medullary carcinoma. So most common or most high yield point on medullary carcinoma is that these are the carcinoma from the C cells or the parafollicular cells. So that's why C cell hyperplasia can be the precursor lesion for the medullary carcinoma. And also this calcitonin, which are produced from the C cells, they can be used as a tumor marker to establish the prognosis of the medullary carcinoma. And these calcitonin are actually the proteins. So these abnormally produced protein from the tumor cells, they gets deposited here within these within these parafollicular cells. That's why they form amyloid. The under microscopy, all you can see is the nest of amyloid cells, nest of polygonal cells within this amyloid stroma. So being amyloid stroma, they are of course stained with Congo red, and under plain polarized light they will give apple green white fringes. And one of the most highlighted point on medullary carcinoma is that they are generally associated with MEN2A and MEN2B syndrome. So MEN2A syndrome, MEN2A and MEN2B syndrome. So the one way to memorize the underlying other pathologies associated with MEN2A and MEN2B is that both 2A and 2B, they are associated with medullary carcinoma. So one is associated with medullary carcinoma of thyroid, that is of course medullary carcinoma, and other is associated with medullary carcinoma of adrenal, that is pheochromocytoma. So both 2A as well as 2B have these two things in common, that is medullary carcinoma of thyroid and pheochromocytoma, that is medullary carcinoma of adrenal medulla, of course carcinoma of adrenal medulla. So what distinguishes mean 2A is that mean 2A generally have parathyroid adenoma or hyperplasia, whereas these MEN 2B have neuroglioma, neurofibroma, or of course neurofibroma. So presence of cutaneous neurofibroma, they indicates the MEN2B, whereas the presence of medullary carcinoma of thyroid with the pheochromocytoma and parathyroid adenoma or hyperplasia indicates the MEN2A syndrome. So these are the familial condition and they are associated with rate oncogene. So you can remember MAID rate. Okay, MAID rate is the rate oncogene associated with medullary carcinoma of the thyroid. Here again we can see the stroma. Here's the amyloid stroma, and we can see the follicular cells within the amyloid stroma. And the last variant is the anaplastic carcinoma. In anaplastic carcinoma, we can see this is the most aggressive form of the tumor. We can see the poorly differentiated cells, and they don't resemble any structures like we called earlier, and so that's why this one is poorly undifferentiated and they are highly aggressive. So they have very poor prognosis, and one of the most feature which helps us to establish that this is anaplastic carcinoma is the age of the patient. So the older age of the patient with the most compelling symptoms like the compressive symptoms of dyspnea, dysphagia, hoarseness of voice, they indicate that this is anaplastic variant of carcinoma. So here we can see undifferentiated anaplastic and pleomorphic cells, and it is associated with TP53 mutation. All right, so this is the key point. You can pause the video and you can note it down. Okay, let's enter into flash quiz. Medullary carcinoma metastasizes through hematogenously. Next flash quiz. Childhood irradiation to severe facial acne increases the risk for, of course, papillary carcinoma of thyroid. Now, some of the questions. Here, a 45 years old previously healthy man comes to the office for evaluation of neck mass. So the patient is presenting with a neck mass, and the patient first noticed the swelling a month ago, and he noticed the swelling a month ago while shaving, and it has progressively enlarged. He has no fever, no neck pain, hoarseness, or difficulty in breathing or swallowing. So his drug history indicates that patient doesn't use tobacco, alcohol, or any illicit drugs. His vitals are almost normal except for his blood pressure, and his under physical examination there are non-tender firm nodule in the upper portion of left thyroid gland. Lab diagnosis shows TSS level is normal and calcitonin level is elevated. Under ultrasonogram, we can see 2 cm hypoechoic thyroid nodules with microcalcifications. Under FNAC, we can see spindle-shaped cells in the amorphous background. So let's explore through this question. So the presence of nodules, a painless nodule, gives us the suspicion that the patient might have thyroid neoplasm, and now he has elevated level of calcitonin. It means that we need to think about the particular thyroid neoplasm which has increased or which increases the calcitonin level in our body. So it can be, so calcitonin levels are produced from the parafollicular cells, so it can be associated with the parafollicular cells. Further, under FNAC we can find these are amyloid cells within amorphous background. So amorphous background must be amyloid stroma. So amyloid stroma are because of calcitonin deposition. So from these findings we can make our assumption that the patient might have medullary carcinoma of the thyroid. Our question is, which of the following gene alteration most likely contributed to this patient current condition? So medullary carcinoma of the thyroid is generally associated with Amian syndrome as well, and both Amian syndrome as well as medullary carcinoma of the thyroid. So I have given you the mnemonics med rate. So it must be rate activation. So the activation of rate is the correct answer. Also, I have presented the genetics here. You can go through it. Second question here, a 30 years old man comes to the office with a neck lump. Patient is otherwise asymptomatic and discovered the nodule incidentally while showering. Past history indicates he has recently discovered pheochromocytoma. This is a very high yield point, very high yield point. Recently developed pheochromocytoma. Pheochromocytoma is the tumor of adrenal medulla, and the tumor of adrenal medulla and thyroid medulla, that is medullary carcinoma of the thyroid and pheochromocytoma, both are associated with, both are the common finding in Amian 2 syndrome. So this can be very high yield point. The patient's father died of thyroid cancer in his early 30s. So it means that the pattern is following autosomal dominant mode of inheritance. So presence of neck lump, suspect thyroid carcinoma in case of thyroid lump unless proven otherwise. Suspect thyroid carcinoma. And the thyroid carcinoma is diagnosed. Now, which one is associated with pheochromocytoma? Make your own diagnosis. That is medullary carcinoma. That is associated with the mean 2 syndrome. Now, he has autosomal dominant mode of inheritance, means mean syndrome. Now, FNA is consistent with a subtype of thyroid cancer. So it must be medullary carcinoma of the thyroid associated with mutation, rate mutation, MED, rate, MED, RET. Please remember it, MED, RET, medullary rate mutation. So it's the neuroendocrine malignant cells, and that must be seen in amorphous background, so which can be stained with the Congo red stain. And we did total thyroidectomy with the central neck dissection. So what question can be asked from all these backgrounds? So the question like one of the complication of thyroidectomy, we talked about complication of thyroidectomy, and the question can be asked about the nature of the cells. So if the nature of the cells is asked, then we can call about these are the malignant cells in a like amyloid background. So let's see what question has been asked. The question is that which of the following is most likely histological finding? So the finding of the in case of medullary carcinoma is, of course, nest of polygonal cells with Congo red positive deposits. So I have marked, highlighted all other variant which can be present here. So our answer is nest of polygonal cells with Congo red positive deposits. You can note this table later. So last question here, a 61 years old woman comes to office due to a neck lump. So we are talking about thyroid carcinoma. So it must be the case of thyroid carcinoma. But if this was not the case of thyroid carcinoma, and a person comes to your clinic with a neck lump, then always suspect thyroid carcinoma, always. And she is otherwise in a good condition. So we have indicated the importance of age in case of anaplastic carcinoma. In anaplastic carcinoma, if the age of the person is mentioned with very poor prognosis, so she is otherwise in a good condition, means she is not having dyspnea, she is not having dysphagia, she is not having dysphonia. That's why she must not be suffering from anaplastic carcinoma. That's a good point. That's a good point, because overall survival rate of the anaplastic carcinoma is less than 6 months. Less than 6 months. So under physical examination, she is having non-tender-form nodule in the left lobe of the thyroid. Her TSS level is normal. So presence of normal TSS, euthyroid condition along with neck lump, always suspect carcinoma. So USG indicates hypoechoic thyroid nodules with increased central blood flow. So here is the increased intranodular vascularity, and there are clusters of the cells with large overlapping nuclei containing sparse and finely dispersed chromatin. So we can make the figure like this. So the nucleus is like this, and the chromatin is dispersed alongside, and there are presence of the intranuclear inclusion. So all right, so we come to know something about this. This is intranuclear inclusion. So internuclear inclusions and the presence of dispersed finely dispersed chromatin, it means like she is having orphan NEI nuclei. So orphan NEI nuclei associated with papillary variant of carcinoma. So our what questions can be asked here is that what kind of mutation might be associated with this type of thyroid carcinoma. So along with papillary carcinoma of the thyroid carcinoma, we need to understand the mutation that is associated, that's genetic factors of the papillary carcinoma. The questions like the histological findings is given here, so there won't be the histological question. So let's see what question has been asked. So suspect thyroid carcinoma, euthyroid condition, directly go for FNAC. No need to go for iodine 131 optic or USG. And the cells, that's papillary carcinoma thyroid. So let's see the question. So the question is, which of the following is the most likely diagnosis in this patient? So the most likely diagnosis is a very simple question. This is very straightforward question. This is a giveaway question. This is papillary carcinoma of the thyroid. Papillary carcinoma of the thyroid. So with this we conclude our topic. Stay tuned. Thank you.